And then there's another student at 7. Some of the training. Yeah. That is cute. There's a I give you the exact destination.
Kimberly, can you type? Wait a minute, I gotta figure out how. Jane Haneke, I need you. Yes. How come I'm not seeing the Zoom on here?
Okay.
Okay, I'm trying to screen share.
Okay, wait a second.
I've got the Zoom on. Kimberly is on now.
Okay.
I'm doing the screen sharing, just so you know.
Kimberly, we're doing screen share. Let me go back to screen share. Where is it? Share.
No, don't do a news share. We're
Okay.
already screen sharing. We need to get the
Let me go back.
components.
How
We
about,
gotta
how about if I stop the sharing?
Oh, I stopped the share.
Okay.
Okay, but it's still not showing up there.
Again, the view is the gallery. So that's everywhere. It's
Yeah,
Kimberly.
but it's not up here. We're not showing the Zoom.
Hey, what the-
Was it?
Okay, you're gonna put it down like that. Not minimize.
I can't, when you're recording the meeting,
Oh,
okay,
okay,
I didn't want to record it yet.
Okay,
I
let's
wanna-
stop the recording.
Okay, I'm trying to find it, okay?
Stop, okay, stop recording.
Okay.
Okay, is that big enough for people to see? Try and do that since we can't do presenter mode. Does that work? That works?
Great.
Perfect. Okay, well, I'm going to be talking about comorbidities of hearing loss today. Yeah. Let's see. What do we go down here? Does that work?
Yeah.
Okay, perfect. Okay, so I'm going to be talking about some of the comorbidities of hearing loss today. So I'm going to be going over different diseases and disorders that often coexist with hearing loss, particularly as we age. And so I'm going to talk about the research behind those diseases and disorders and its relationship to hearing loss, what audiologists can do, and then what other hearing and non-hearing care professionals can help with. So please feel free to raise your hand if you have any questions, and I'll check in for questions at different points throughout. Okay, so let's see how. Perfect. So a little bit about me. I was born and raised here in St. Louis, Missouri. I actually grew up in the Afton area. I went to St. Louis University for undergrad, where I got my Bachelor's of Science in Communication Sciences and Disorders. And then I went to Washington University in St. Louis for my doctorate in audiology. So I like to joke that I've never been able to leave St. Louis, and I don't plan to at this point either. I graduated from WashU's program this past May, and while I was at WashU, I was a research assistant, and then after graduation, I was a research audiologist in the auditory wellness lab at WashU, and their research focuses on hearing and cognition. And I worked under Kate McClanahan, and she was really helpful in this slideshow presentation. She sent me some really good journal articles, some really nice slides. And so if you have any questions or you want me to send you any journal articles at the end of this, just let me know. I can pass them along to you. Alrighty, and then, okay. And so I am an adult audiologist. And so all of the research I've participated in, all of the patients I've seen, they are all in the adult population and focused more on the aging adult population. I'm currently a clinical audiologist at WashU now, working at the CAM building at Big EJC, and then also at the West County location. Alrighty. So hearing loss comorbidities. Oh, it's not going to have the fun effects. That's okay. We're just going to skip through the fun effects of the slideshow. So conditions that often coexist with hearing loss is what's considered a comorbidity. So that just means, as we age, we are more likely to also experience things like vision loss, cardiovascular issues, cognitive decline, and that may not be due to a cause of the hearing loss. So there might not be a causal link, but they just occur together because those things typically occur as we age. So that's a comorbidity. So I'm not saying hearing loss is causing these things, just that they're often found together. Okay, so the first kind of subject matter I'm going to get into is mental health and hearing loss's effect on mental health. And so it varies a lot in the individual, in their personality, in their cognition, and how much hearing loss affects your daily life. Some research has shown that there is increased anxiety and depression symptoms in individuals with hearing loss. This research focuses more on individuals who progressively have worsening hearing loss as they age. It's not as focused on individuals who've had hearing loss since childhood. So they find typically more anxiety and depression symptoms if you had normal hearing and then slowly developed hearing loss over time. They often found there's higher anxiety in younger individuals who have hearing loss, and this is often thought to be because it's more impactful in the daily life in terms of working, social events, things like that, that younger individuals typically take part in, and there are less other young people who have hearing loss with them. Yeah. Oh, sorry. Oh, sorry. Perfect. And then this can ultimately lead to social isolation and or loneliness. And so that's kind of the biggest thing that audiologists and doctors typically focus on. I think in a group like this, where you have a lot of people together, it's not quite as big of a concern. However, it's the individuals who don't know other people with hearing loss that they often see the biggest impact on mental health. Okay, and so I'm a very action-oriented person, so I'm going through different things an audiologist might do to help an individual's mental health, and then we're going to skip to other health professionals. So obviously, an audiologist is the specialist on amplification options, so hearing aids and cochlear implants, and that's what's used to provide help in the difficult listening situations. And so the goal of that is to make sure that person isn't withdrawing from those social situations by using the hearing aid and the implants. The research has found that individuals who have hearing loss and use amplification devices have lower odds of anxiety and depression symptoms than other people who don't use hearing aids. And there's also in surveys a decrease in the perception of loneliness. So one of the biggest things you can do for your mental health when you have hearing loss is to find the amplification option that works best for you. Sometimes an amplification like hearing aids or cochlear implants is not enough. And so you need additional devices like a TV streamer, mini mic, caption telephone. And so that's another thing where when you're talking with an audiologist, you would just mention what types of situations you're struggling with, and they would add on those additional devices. The biggest thing that we recommend is discussing good communication strategies for friends and family. A lot of people don't really realize they have poor communication strategies. And so recommending a person face the speaker, speak clearly and naturally rather than talking louder, eliminating background noise, capturing the attention prior to changing the topic of conversation or starting communication. And then, of course, revise, don't repeat. So if you just repeat the same thing over again, you might still miss those same sounds. But if you revise what you're saying, you'll get more information cues to kind of put everything together into more of a big picture. And then for the listener, what we can do is if we mishear something or someone, we repeat the portion that we understood. And so that way, instead of just saying what, and they have to repeat the whole thing, we would be, I put the glasses on the what, or where did I put the glasses? So they can just say the one part that we missed. We can confirm that we heard it correctly by, did you say the glasses are on the table? Or we can ask for them to rephrase completely. But the biggest part is being assertive and making sure people are aware when you need someone to repeat, rephrase, or clarify. All righty, and so then beyond the audiologist, so oral rehabilitation, they do have options with a speech language pathologist to have oral rehabilitation if there are specific situations you're struggling with that you feel are leading to more social isolation. St. Louis University Speech Language and Hearing Clinic, and then Fontbonne University's Speech and Language Clinic. Both have speech language pathologists and will work with you on wherever you notice you're having those needs. They are both free, but typically have a wait list. And I know Fontbonne actually goes to those difficult listening situations and has you practice with a speech language pathologist, which can be really helpful. Online options would be Angel Sound, which is free, Amplify, and LACE auditory training. And that just gives you more strategies for specific types of listening situations. Okay, and so then when is it time to seek counseling? So sometimes you really notice you're struggling in situations and you've exhausted your means of trying different methods of amplification, assistive devices, communication strategies. And it's time to talk to someone more about the anxiety aspect. There are counselors who specialize in hearing therapy or hearing psychology. And so you can talk with them about when you're in difficult listening situations, how to understand your anxiety and how to cope with that rather than just the listening. So this is very important for people who have like sudden hearing losses and all of a sudden have to cope with all of these changes in different social situations, or have had quickly progressive hearing losses and such like that. And then of course the ADA reminder that an audiologist is always there to write you a letter of necessity if needed, to help you find accommodations that are in public, at work, all of that jazz. Alrighty. And so the next big topic, which is kind of more of the hot topic in the field of audiology, it's kind of the one that stops the presses, we like to say, and that's cognitive decline and dementia. Alrighty, and so when I'm talking about cognition, I'm talking about the mental action or process by which information is learned, stored, and used. So that just basically means it's all of the processes of remembering, thinking, and using information. And so then cognitive decline is just when any of those processes either stop working or get a little worse with time. And it's very typical to have cognitive decline as we age. So cognitive decline ranges from normal to abnormal, and we'll kind of go through the differences today. Cognitive decline is not synonymous with dementia, and so we'll talk about that as well.
So you are going to clarify which one?
Oh yeah, we'll go through all of it. Okay, and so this lovely chart here with all of the colors kind of goes over what's typical for cognitive decline. So we can see those light cool tone colors, the blues, the greens. That's all of the things that tend to go down as we age. And you can see the years at the bottom of what's typical. And that speed of processing, or how fast our brain is able to interpret the information in our surroundings, our working memory, which is how fast and how well the brain takes in multiple types of information at the same time. So that would be like complex tasks, or doing two things at once. That becomes harder as we age. Long-term memory, so remembering way back in time, or especially if you haven't done something recently, but you did it a long time ago, it's not as easy to pick it back up again. And it's also not as easy to pick up newer hobbies that require a lot of repetition. It's a lot harder to kind of form new habits. However, things that stay the same or even get better as we age includes world knowledge. And so world knowledge are the things we do on a daily basis. So it's the habits we formed a long time ago and continue to do to today. And then it's also things like our vocabulary and our understanding and interpretations of what people are saying and their meaning behind their actions. So we're still very good at understanding what people mean to say and when they're talking. We just have a harder time processing when they're talking quickly, like I kind of am today, or when there are multiple things going on at once. Okay. And so the biggest thing is it kind of creates this hierarchy of where we have a decline in processing speed. So we don't incorporate everything as quickly. And then if we have hearing loss and we miss certain sounds or phrases of what people say, our brain doesn't fill in the gaps as quickly. Whereas when we're younger, our brain can fill in everything as long as we know the topic of conversation. And then it slowly gets a little bit harder. And then if you add in background noise, sound coming from different sides of you, it becomes even harder to understand speech or where sound is coming from. We also have a decline in attention. So that's selective and divided attention. So selective attention is when we're trying to focus on one thing and get rid of everything else around us. Just pretend like it doesn't exist. So if we're in a noisy area and we have one person talking in front of us and someone talking behind us, if we can hear both talkers, it's harder to just focus on the talker in front of us. Divided attention kind of goes back more to the working memory aspect of where we're trying to focus on two things at once. So we're watching someone play on the playground, but also trying to hold a conversation at the same time. It's hard to do both things. The biggest thing is a decline in that retrieval of newly learned material. So it's harder to create those new habits. And so if we change technology, so get new hearing aids, new implants, things like that, it's harder to learn that new routine, or if they change how they change a microphone filter, change a battery to rechargeable, remembering to charge it, things like that, is a lot harder to remember as we age than it is from when we're younger. But this is very typical. And so then we start to see a mild cognitive impairment in some individuals. And so that's just as we age, it's a little bit more decline than an average person, but not enough to impact our daily living. And so some mild forgetfulness, so more difficulty maintaining attention in a conversation, sometimes having a harder time finding what word you're trying to use or word you're trying to say, and then difficulty with more complex tasks like managing or balancing a checkbook becomes harder when it didn't used to be hard. This can progress to dementia or it cannot. So it's kind of, it depends on the person for how quickly the cognition declines versus kind of staying stagnant over time. And then with dementia, this is when it starts to impact our activities of daily life. So when we see someone having personality changes, if they're having behavior that's not typical for themselves, difficulty with more basic activities that they used to have no problems with, more difficulty in conversation, finding the words, sentences, not being able to stay on track in the conversation because they're really focusing on one thing that you may not deem quite as important. Or also we start to see more tripping, falling, and balance concerns. But this is also normal with aging as well, and we'll get into that too. And so there's a variety of types of dementia and effects. And so one person might experience significant personality changes, but none of the other symptoms. And so it really depends on the individual, what's causing that dementia, and what they're doing moving forward. Hearing loss and dementia is that big hot topic that we started seeing a few years ago pop up. All of the hearing aid manufacturers, cochlear implant manufacturers, all of them started telling everyone that hearing loss causes dementia. And there really hasn't been a study that shows a causal link of that. So I think we have to take that information with a grain of salt. Absolutely, it makes sense. If all of a sudden you're not hearing anymore when you used to hear, your brain is suddenly missing a lot of information. So it makes sense that something would happen to the brain to affect the functioning. But it doesn't mean that you're absolutely more likely necessarily to get dementia if you have hearing loss, especially if you're treating that hearing loss. Because there are a growing number of studies that also show that while hearing loss is a risk factor of dementia, wearing hearing aids, cochlear implants, and amplification significantly decreases that risk. And it's really less of a causal risk and more of a just anecdotal data that shows, okay, so yeah, this group has hearing loss, this group doesn't. There are more people in this group with dementia and cognitive decline, but if you take out the people who use hearing aids, less of those people have the dementia and cognitive decline. Still not enough people to show a significant causal link though. There are 3 hypotheses that kind of go into this of explaining it because we don't necessarily know the exact mechanism why hearing loss leads to more cognitive decline. And so that's the sensory deprivation hypothesis, the information degradation hypothesis, and the common cause hypothesis. And so sensory deprivation hypothesis, so that's when you had normal hearing, or you then had a slow decline in hearing loss. You're not using amplification to provide sensory information to the brain. The brain's going to atrophy. Those portions of the brain that used to have that sensory information are going to slowly decline, and that leads to an overall decline in brain health. Information degradation hypothesis is that our brain is working extra hard to hear our surroundings, piece together words that eventually over time it slowly degrades. Common cause hypothesis is that one thing is causing both things. It's not one or the other. So hearing loss doesn't cause dementia. There's another thing going on in the brain that's causing both. Because we see that cognitive decline is typically less severe than with those who wear hearing aids, we typically take out that common cause hypothesis and we assume more is closer to the sensory deprivation or the information degradation. Because when we give our brain access to that sensory information and keep it moving like before, we're less likely to see that progression of cognitive decline. And it's not necessarily that you won't get cognitive decline. If your genetics or you're predestined to have cognitive decline based on other family members, different aspects in your life non-related to hearing loss, the hearing aids typically just slow the progression of the decline. It's not necessarily a cure. And then over time, both cognitive function and hearing abilities decline. So it's hard to say, one is causing the other because so many people experience both. It's just a typical, as we age, we're more likely to have hearing loss, and as we age, we're more likely to have cognitive decline. So it's hard to separate them out to really decide what's true and what's false. And we can see we're actually expected to have an increase in cognitive decline and hearing loss over time. You can see the projected numbers on the chart here are just slowly increasing, which is an interesting note for population that more people would start to experience both. But ultimately, so what most researchers theorize is that hearing loss leads to compromised speech perception, which leads to greater communication effort. And when you have too much communication effort, if you isolate yourself from those communication difficulties, so you stop going to social events, then that leads to more loneliness, which then impairs your cognition because you're not out as much, using your brain as much, which ultimately leads to the cognitive decline. So that's the current theory. But it's completely up to the person and how they experience their hearing loss, of if they actually begin to socially isolate themselves. That's one of the big research topics Kate McClanahan is looking at, because two people with the exact same type of hearing loss experience that hearing loss very differently. And there are a ton of factors such as age of when the hearing loss began, if they're using treatment options, their surroundings, family support, friends support, all of that plays a big role. So you can't really put yourself into one category. And so that's what the current research at WashU is looking at, is why some people don't notice the hearing loss difficulties as much as others. And so, of course, early identification of hearing loss and treatment is always what we're going to recommend. While we can't prove hearing loss causes dementia or cognitive decline, there's enough evidence to show that there's probably a relationship there. And so the earlier we identify it, we might as well try and treat it as early as possible, just to see if it can help potentially slow the progression. Also, because we see that it's harder to learn new behaviors as we decline in cognition, it's better to get all of that training in before we start to see cognitive decline, because it's easier to form the habit of using the devices. Okay, so we're going into the risks of falls. So our balance system is located in our inner ear. And so we have the cochlea, which connects to the auditory nerve. And right next door, we have these semicircular canals and vestibule, and that's our balance system, which connects to the vestibular nerve. Which is why if you ever have imbalance or dizziness, we always recommend you get a hearing test, because sometimes that balance and dizziness can have a relationship with hearing loss, where we can see it show up. As we age, our sensory and motor systems that contribute to balance can slowly decline as well. So our sensory hair cells, so just like in our inner ear that have hair cells that help us hear, we have balance hair cells that also help us stay balanced. And these hair cells slowly decrease. So just like our hair cells slowly decrease in our ear, that leads to gradual progression of hearing loss as we age or presbycusis, those sensory hair cells in the balance system also slowly decrease with age. So this decreases what's called our proprioception ability. So proprioception is just kind of where we are in space. So I know that I'm standing here, my feet are on the ground, there's a table in front of me, I can feel where I am in space. But if we stop knowing exactly where we are, that proprioception declines, we start relying on our other senses in order to understand where we are. So if I close my eyes, I know where I am. But if I open my eyes, I can see a table in front of me, I can hear other people around me, I can feel with my feet on the ground. And so I use those other senses when my proprioception declines. However, when we age, those other senses also decline, which is why it's easier for us to become imbalanced. And then over time, we start to have more risks of falls from the imbalance. We also have a reduction in our muscle fibers. So while it's also easier for us to fall, it's harder for us to catch ourselves, and it's harder for us to avoid injury with a decrease in muscle fibers, which is why doctors, audiologists, primary care, everyone is always very concerned about balance right now and the risk of falls, because it can have a huge impact on your quality of life. Cognitive decline leads to you having a more difficult time doing two things at once. So it's that having a hard time focusing on one task while trying to simultaneously do the other without working memory. And so if you're doing a difficult task with a cognitive decline, you're going to have decreased balance because your brain is focusing on one thing, and so it's not focusing on the balance. And this can lead to a more sedentary lifestyle. And then a more sedentary lifestyle decreases your movement, leads to more muscle atrophy and increased imbalance. So the best thing we can do as we age is continue moving. So walking, staying very active in our social settings, keeping the brain active, keeping our muscles active. That'll help with both cognitive decline and falling. There is some evidence that shows there's an increase in number of falls with an increase in hearing loss. This is more hearing loss of progressive nature, or presbycusis hearing loss is what the research studies have shown. And it makes sense, you know, when we lose some of our sense, when our brain's not used to that, it has to slowly learn to compensate as we're losing our sense. And if it doesn't compensate quick enough, that sense is out of the picture and it's harder for us to catch ourselves. If we have a really slow progression of hearing loss or hearing loss for a very long time, our brain has compensated for that. And so you don't necessarily see that same increase in number of falls that you would for a quick progression or sudden hearing loss, things like that. So our hearing aids, the answer, really help with balance. We don't really know. Use of hearing aids may reduce the risk of falls. There have been a few studies that have shown people who use hearing aids report more comfort in walking in their balance. There is one study that actually showed a true increase in balance when doing balance tests, but most of the time it's more quality of life and peace of mind that people experience just because they feel like they're better aware of their surroundings. Hearing aids will not cure imbalance though, and I've actually seen on several flyers that they will, but just keep in mind that they may help with quality of life and feelings of balance, but they will not cure imbalance. If you are ever concerned about your balance, talk to your doctor. You can be referred to a physical therapist and they will help you with balance exercises. They have balance training. It's called vestibular rehab. So it helps if you experience dizziness or balance concerns. And so they'll work with you, with whatever movements you're concerned about, strengthen up your muscles, just to get you a little bit more active, more comfortable being active. Some other health conditions would be diabetes, cardiovascular disease, and vision loss. And so we're going to kind of do a quick dive into each of these. So for diabetes, diabetes actually can lead to hearing loss. There is evidence of more of a causal link than with things like cognitive decline, mental health, falls, and that's because anatomically there's a reason that it's causing hearing loss. So diabetes occurs when we don't make enough insulin or our body doesn't utilize the insulin appropriately. And so insulin allows the sugar to enter our cells and our bloodstream, maintains our blood sugar. If we have too low of blood sugar or too high of blood sugar, it can actually damage the cells within our ear, along with cells all over our body. And so one of the most important things that we can do is maintain our blood sugar levels. High blood sugar levels can damage the vessels and the stria vascularis in our ear. And so inside our cochlea, we have different membranes, and we have different levels of different ions and nutrients and all of that jazz. And so the stria vascularis make sure all of those levels are in peak condition. And if for some reason it's not in peak condition, that's when hair cells can be permanently damaged, or sound won't get through the hair cells to the auditory nerve because it's not functioning appropriately. And so that leads to hearing loss. So hearing loss is twice as common in patients with diabetes. It's 30% higher in those with pre-diabetes, and it can actually increase the progression of your hearing loss. So it can make it you lose your hearing faster, particularly if the diabetes is not managed appropriately. Typically, if your blood sugar levels remain pretty standard over time, the diabetes won't affect your hearing. It's only when you have those extreme lows and extreme highs where it can. Okay, and this is way beyond a typical audiologist scope, so definitely talk with your doctor about management options. And they'll tell you what levels would be maintained appropriate, foods, diet, exercise that they would recommend, all that good stuff. Cardiovascular disease is very similar to diabetes in terms of how it affects our ears. So we have reduced blood flow to our ears, which can of course just lead to damage anytime blood doesn't get to certain extremities. It's not providing the nutrients it needs, and it's also not taking out any waste within those extremities. Our ears actually pick up a lot of, it can actually pick up a lot of toxins. So any medications that we take, those medications can go to our ears. And so if that medication is toxic to the ears, reduced blood flow, it won't clean out those toxins fast enough. So that can lead to more hearing loss, as well as just not the appropriate nutrients and things like that, that the ear just needs on a daily basis, leading to hair cell damage, nerve damage, depending on the amount of cardiovascular disease. And then of course, this is also way beyond an audiologist. So if you're experiencing any symptoms of cardiovascular disease, chest pain, slow heartbeat, shortness of breath, pain, numbness, lightheadedness, anything on the screen, please immediately call your doctor. They'll work with you on a plan to make sure you're getting back to tip-top shape, and then to prevent any possible long-term effects of the disease. And then finally, we're going to talk a little bit about vision loss. Vision loss is different from diabetes and cardiovascular disease in that we don't see a causal effect. So vision loss will not lead to hearing loss, and hearing loss will not lead to vision loss. Instead, it's typically some underlying thing that leads to both. As we age, it's typical to have a decline in our hearing and a decline in our vision. And so, which is why we often see it together, unless there's a genetic syndrome involved, in which you typically see it earlier in your life that both are affected. If you have vision loss, though, definitely talk to your audiologist about it. Or if your vision changes, talk to your audiologist about it. They can change their recommendations of size of devices, color coding. You can get 2 different colored devices, which can be helpful. They have different things if you have batteries, like a little magnet to put the batteries in the hearing aid for you, so you don't have to fiddle with them quite as much. Or of course, switching to rechargeable batteries, which would be easier. And then use of amplified telephones versus captioned telephones, so just making the sound louder for you if you're not able to read the text on the screen. I think I'm always recommending captioning telephones to individuals, and it's something I don't think about enough to ask. But kind of like the biggest thing is just talk to everyone, tell your audiologist any of your concerns. If you start to notice you're withdrawing from social situations, try to make a game plan of what you need to get back into those situations. Talk to your primary care about concerns of balance, concerns of cognitive decline. There are quick screeners that can be done in an office in 5 minutes or less, which can put you on good track about managing diabetes, cardiovascular concerns. Basically, just talk to everyone about any concerns you have, because you are the only person who knows everything about you. Okay, does anybody have any questions? I think I just sped through that so quickly.
If you have any questions, that might choose. The possible to have like these stroke in the processes.
Yeah, absolutely. And that's something we do see sometimes after, if you have a stroke, your word understanding will go down. And so you'll still feel like you can hear the same amount of sound. You just won't process it the same way. So your word understanding will go down. And that's also when they might start recommending things more like switching from hearing aids to a cochlear implant. But you'll always have to be aware that it's your brain function, not the nerve function, that's leading to that. So more like auditory training would be helpful. So that's when you might want to work with like a speech language pathologist for oral rehab to learn coping mechanisms for different situations, or those online trainings that I mentioned would be helpful. but it definitely can impact your speech understanding. I'm sorry. Okay, so yeah, and that's a good question. So the question was, so the mother has hearing aids, can't get her to go back to the audiologist. And it's been about 3 years. And is she struggling? Yeah. Yeah, and so I think, you know, the biggest thing you can is explain your situation of you're struggling. Maybe you can go together to the audiologist. Oh, that definitely makes it harder. You can't really force someone to go. No, well, so then maybe start researching articles about, you never want to use like cognitive decline or anything as a scare tactic, but just having the conversation of, you know, your life could be more fulfilling. You know, if you notice she's withdrawing from social situations because of it, you know, you can mention like, yeah, I use hearing aids or implants or these devices, and these have really helped me in these situations. I would love to see it help you in those situations. Oh, that's a great idea. A quick video on how. Sorry.
We have a visitor and she said a new video will be needed to how to talk to your audiologist. So maybe that's something that we can invite both Courtney and Christy. Any more questions?
One thing that I know with hearing loss, is it it's hard to acquire don't have hearing loss.
Oh yeah, so the question was, with hearing loss and aging, is it harder to acquire new information if you have hearing loss versus not having hearing loss with aging? I don't know if there's any specific research directly on that. My guess is, you know, if you're having a harder time understanding the new information because of the hearing loss, potentially, but I wouldn't expect you to necessarily, because you have hearing loss, not be able to pick it up as quick as someone who doesn't have hearing loss. I wouldn't expect there to be a big difference, but it's not something that's probably been studied directly.
Okay. So how are actually learning rather than doing so for people with hearing loss, and also recommendations or modifications.
Yeah, so she mentioned, you know, they used to recommend doing like those crossword puzzles to maintain cognition, and now they're recommending building on new skills or creating new skills, learning new things. What was the last part?
So I'm wondering if hearing loss.
Oh, okay.
They'll say take a new musical instrument, learn a new language, or I mean something where you're really yourself to learn new skills.
Yeah, so will hearing loss impact your ability to acquire a new skill? You know, I think it depends on the person, the amount of hearing loss, and what skill they're trying to acquire. I think in general, no. I think if you're trying to acquire a new skill and you're working at it, the earlier you start learning those new skills, the better. And so if, you know, each year, you're like, I'm going to learn this each year, your brain is going to stay really active, whether you have hearing loss or you don't have hearing loss. And I think it's just important that you don't stop acquiring new skills, and then down the road when it is already harder to acquire new skills, start kind of pushing it into gear. It's better to come at it from a, this is forever, I'm always going to keep working on this, because you don't want to get to the point where it becomes harder. But I don't think hearing loss would make it harder to acquire a new skill.
When I'm in social situation and I'm being used, I find it very challenging. I'm running in. Later on, I remember the physical, but I don't remember the name. I don't know why I didn't do it, but I'm doing it. So, if something that help retain.
Okay, so the question is, it's harder with hearing loss to remember, like when you're in a social situation, somebody's name along with everything going on. You'll remember the person, but not necessarily the name. And is there a trick to make that easier? So what you're talking about is called auditory fatigue. That's what we typically say. And that's just the brain is working so hard to hear in the situation, it's forgetting the things that it doesn't deem quite as important. It's also why you might be more tired than someone who doesn't have hearing loss at the end of the day, because you're working so hard to hear everything. Something that you could try is honestly more of the brain training games, less about the hearing loss. Of course, if you're in a situation and a person could use like a mini mic that streams, that would be helpful. Your brain might not have to work quite as hard to hear, like from differentiating from the background noise. But ultimately, that's more of the brain. And so those, the oral rehabilitation, so even just playing those online games, the free games that you can find online where you practice listening, it just puts your brain in a mode to always be listening, practicing in those tough situations. It's kind of like strengthening a muscle. So the more you practice, the more you work, the stronger the brain will get at it. But it's something that could also, it's just going to be more difficult. But you could always try something like a mini mic or something like that if the social situation allows for it.
There's a thing called moments, and it's like I say, Bob, the things that she's those might be really helpful.
Yeah, and so she mentioned like mnemonic devices of if someone's named Bob, they wear a blue shirt, Bob in the blue shirt to help you remember it. Another thing similar to that I've seen people use is called building a house. And so when you're in a situation and you meet Bob, you put Bob in this house, and Bob has a blue shirt, so it becomes a blue house. And then he's talking about, maybe Bob likes gardening. So there's a big garden in front of the house. And so instead of creating an auditory memory, you're creating a visual memory of Bob. And so then when you think of Bob, you think, okay, Bob, blue house, gardening, and you can remember more about Bob and then ask him about gardening next time you see him. So that's another thing, but it doesn't necessarily help with the name, more of the personality of a person.
I think also just when they didn't repeat everything you made, say that to make sure it's perfect, probably. Maybe
Yeah, and so that's a good tip of just asking to make sure you got the name correct, including the name later on in the conversation. So that way when they're leaving, like, nice talking to you, Bob. Helps you remember Bob later on. I should probably start doing that. I'm very bad with names.
Thank you so much for attending.
Thanks.
Good topic, and we do have recorded it. And, we can also put it in YouTube, right?
Yeah.
So for future, we can.
Exactly, I like that.
Right. Kim, I just said that, it would be on YouTube and I had been recorded, so if someone wants to see it in the near future, available. Okay, can you understand me, Kim? Stan, okay, yes, I'm here. Can you hear me? Yeah, she's got me now. Okay, thank you. If you want to hang around here for a few minutes, maybe you think about something that you want to discuss with Courtney. And there's a couple things. Is it working? Okay, it is working. A couple of things. Gilbert, Deborah was bought this brochure about a new technology. That's Delbert. D-E-L-B-E-R-T. He bought this brochure of this new technology. So I'm gonna pass this brochure around, kind of quickly look over it. If you're interested, there's a phone number and a website if you want to take more time to learn more about it. I don't know anything about this technology. What is it, Deborah? I didn't understand what you said.
Oh. It's the hearing aids. So it's a hearing aid that sends the sound down to on itself. So the hearing aids is
Okay. All right. It's a device. Could you just repeat that?
Yeah, so she mentioned that it's a new type of hearing aid that has a piece like kind of like a contact lens that sits on the eardrum almost. So it's, I think what I know about it is kind of in between a hearing aid and a cochlear implant. If you're not quite ready for the implant, you can try it. I personally don't know anyone with it, so definitely read the brochure if you're interested in learning about it.
Thank you, Courtney, for helping me out here, because I couldn't hear. And also, October is Protect Your Hearing Month. I don't know if you look at our Facebook page, but I usually get some information and I share it on the Facebook page. So does Kristen, and I believe Kathy does too. So please take a look at the Facebook page and please circulate that Facebook page for people to like so that we can get more people hearing about us. And we also have two visitors that I'm aware of. Jane, Lara, just raise your hand. And the lady in the corner, I didn't catch your name. Jessica. Welcome, Jessica and Jane. We always like new visitors. I hope you become members. There is a brochure that will discuss that. And please, members, welcome our new visitors here. Hope to see you again. And next month, November, we are going to have, well, we don't know if we're going to have a representative from Oak Tree or Kristen Kramer. We'll talk about assistant listen devices or system. And if you use them at home, your own, bring them to us in November. It's yours when we're done. After you demonstrate, you certainly can take it home. It's like show and tell. If you remember show and tell, you know, show what you got. Tell us about it. So, yeah. Yeah. I do. I didn't say thank you for coming. I really think this is a good topic. She still can't get me. Okay. Any announcement that you want to make? Okay. I told you about November. December, we're back at Helen Fitzgerald for a Christmas party. The steering committee has not met yet on how much to charge the members, but I will expect it be between $20 and $25. And you have to RSVP to Laura Cacciatero because she will be collecting the money. Okay, thank you for coming. And don't forget, return your name tags to Diane. And I hope you see you next month. Thanks again.
So Kathy, did nobody else join?